From the JAMA Network, this is JAMA Ophthalmology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Ophthalmology.
Hello and welcome to this author interview from the JAMA Network. I'm Neil Bressler, Editor-in-Chief of JAMA Ophthalmology, and today we're going to be discussing the cost-effectiveness of Aflibercept monotherapy versus Bevacizumab-First followed by Aflibercept if needed for diabetic macular edema. And joining us is the first author of that study, Dr. David Hutton, who's been working on this planned secondary outcome from Protocol AC of the DRCR Retina Network. Dr. Hutton is an associate professor of health management and policy at the University of Michigan School of Public Health in Ann Arbor. David, thank you for joining us.
Thanks for having me.
Maybe we could just start with Protocol AC. What was that protocol? What was the primary outcome and what did they find?
Sure. And just a little bit of background. A lot of people are concerned about the best strategies and best treatments for diabetic macular edema. And prior to Protocol AC was Protocol T, which found that Aflibercept had better outcomes for those with worse starting visual acuity. So Protocol AC was designed to see which would be better, starting patients on Aflibercept monotherapy or starting them with Bevacizumab first, and then switching to Aflibercept monotherapy if they weren't seeing a good response.
And as I understood it, they found out that actually one strategy was not superior than the other. If you started with Aflibercept, you ended up with improved visual acuity. And if you started with Bevacizumab and switched to Aflibercept if needed, as determined by the investigators at the start of the study, one visual acuity outcome was not superior to the other. So walk us through this planned secondary outcome, and that is to look at the cost effectiveness. If we know that the visual acuity is not superior with one or the other, how do we then look at cost effectiveness?
Yeah, that was the planned secondary outcome. And part of this is Aflibercept is much more expensive than Bevacizumab. It's about $1,700 more expensive per dose. And so we wanted to ask the question, is it cost effective to use Aflibercept or start with this Bevacizumab-First approach? And like you said, if the vision outcomes aren't better with Aflibercept, it's hard to justify that Aflibercept would be a valuable treatment strategy to invest in.
So how do you calculate cost effectiveness? What goes into determining that beyond just what the visual acuity outcomes were?
Sure. And at a high level with cost effectiveness, we want to look at both the costs and the health outcomes associated with different intervention choices. And if something's more expensive, that doesn't necessarily mean it's bad. If we have better health outcomes, it might be worth spending money on it. We might be willing to pay for those better health outcomes. Now, when we measure health outcomes in cost effectiveness analysis, we want to measure them in a very specific way. We want to measure them in terms of something called a quality adjusted life year. If we measure things in terms of quality adjusted life year, that means we can make evaluating an intervention for ophthalmology comparable with other interventions for other areas of health. And what a quality adjusted life year is, it's basically equivalent to a year in perfect health. And we know vision is an important part of health. And so if we can improve someone's vision, we can improve their quality of life. And that would be part of this quality adjusted life year. And so we're looking at how much are we paying to get these quality adjusted life years when we invest in presumably a superior health intervention.
So walk us through the data that you looked at then. What were the costs? What was the utility that you talked about? And what did the cost effectiveness end up being?
Yeah, so we did find that there was a slight improvement in quality adjusted life years or vision outcomes with Aflibercept. The improvement was 0.015 additional quality adjusted life years over a 2-year time span with Aflibercept monotherapy versus the Bevacizumab-First strategy. And with that said, the Aflibercept monotherapy strategy had an increase in costs of $12,575 as compared to Bevacizumab-First. So it was much more expensive. and there was a very, very small improvement in quality adjusted life years. If your readers read our paper and they look at the first figure, figure 1, and they look at the quality of life over time, you really have to squint or pull out a magnifying glass to see what is the difference between Aflibercept monotherapy and Bevacizumab-First. These numbers are very, very similar, and so it's a really, really small increase in quality adjusted life years. Now, again, an increase is an increase. You might be willing to pay that, but the problem is paying $12,500 for that kind of improvement is quite small. When we work it out on kind of a population level, if you were a payer paying to purchase quality adjusted life years, you'd be paying over $837,000 per quality adjusted life year that you'd be gaining. Now, that's actually really expensive. Typically, people in health economics might be willing to spend $100,000 per quality adjusted life year. So this is much more expensive than we're typically willing to spend for a lot of medical interventions.
I think I get it, but let me repeat it back to you. So actually, the study found that there was a small or relatively small advantage of Aflibercept first compared with Bevacizumab first and rescuing with Aflibercept. There was a small advantage for quality adjusted life years in the Aflibercept group. But the cost was so great in the Aflibercept group compared with the Bevacizumab and give Aflibercept if needed group, that small increment of the better quality adjusted life years in the Aflibercept group was almost outweighed by this greater cost, so that the overall cost effectiveness is just not good enough for what people look for. I think you said they look for maybe $100,000 quality adjusted life year, and in this case, it's over 800,000. Is that right?
Exactly. The improvement in terms of these quality adjusted life years is very, very small, and we're spending a lot of money for those improvements. And so when we work it out, again, you're spending 8 times more than most people would say is a reasonable amount to spend to purchase, if you will, quality adjusted life years. Maybe I'll point out one other thing too. The improvement in quality adjusted life years, we estimated that we think you'd gain 0.15 additional quality adjusted life years, but that wasn't even statistically significant. There was some error on that estimate, and it's not even necessarily different from zero. So even if we're kind of optimistic that we are getting this 0.015 increase in quality adjusted life years, there's some uncertainty around that, and because it's such a small increase in quality adjusted life years.
So, were you surprised by the results? Are there other examples in medicine where there's such a large cost difference that one might not have anticipated this? Or could we have surmised this and you've now given us sort of precise numbers to deal with?
I think this wasn't too much of a surprise. I think the prior research on some of these anti-VEGF therapies for diabetic macular edema have suggested that bevacizumab has very similar outcomes to Aflibercept and ranibizumab. So it would have been a surprise to me if we had found that Aflibercept monotherapy was cost effective compared to Bevacizumab first, because the health outcomes or the vision outcomes are so similar. And we know that the cost increase by using Aflibercept is so much more expensive than Bevacizumab. This wasn't too much of a surprise. Now, with that said, sometimes, though, we do get surprised. Sometimes we do see expensive interventions. If they can give a big improvement in quality of life, then they can prove to be cost effective. But that isn't something we're seeing in this case.
Now, of course, we don't know whether everyone will be treated in the way they were treated in this study. And so we don't know if the vision improvements would be similar if somebody misses 2, 3, 4 visits and starts with one strategy versus the other. Could we look in the future at large insurance databases to see how people actually are coming back for treatment, to understand if maybe the vision outcomes are not always the same if you start with one strategy or another? Will that be a worthwhile pursuit in the future?
Potentially, that could be interesting to look at. Oftentimes with insurance claims databases, you can look, like you said, at a longer time period, and maybe we would see some outcomes that would be different over the longer time period. And sometimes, what happens in the real world is different than what you observe in a clinical trial because it's such a controlled environment in a clinical trial. With that said, I guess I might expect to see a Bevacizumab-First therapy look even better in the real world simply because of copays and The high copays for Aflibercept might actually prove to be a barrier to people actually getting anti-VEGF therapy, and they might drop out more frequently with Aflibercept than Bevacizumab-First. And so I think in the real world, those kind of financial barriers actually might lead to higher dropout rates in an Aflibercept population than the Bevacizumab population, and therefore, might make Aflibercept look less attractive in the real world as well.
And of course, there always are some individuals in whom somebody might want to start with one agent versus another. For example, if they started with bevacizumab in their right eye and were immediately switched within 3 months to Aflibercept, that person might say, again without proof, I'd like my left eye treated in that way. But I think for now, you've shown us that we have very good numbers to suggest there really is no rationale from the cost effectiveness data in a group of people to be starting with Aflibercept compared with Bevacizumab-First and switching to Aflibercept. Is that right?
Yes, and I should say, this study just looked at people who had one eye that was treated in this sub-analysis of the economic analysis. We just looked at people with one eye treated. And so you're right, there might be some cases where it might be reasonable to start with Aflibercept first, like you said, in the fellow eye, if that started to need treatment later on, and bevacizumab didn't work the first time. I also want to highlight, too, that part of this, the cost effectiveness, of course, relies on the price of the anti-VEGF therapy. And the price of the anti-VEGF therapy could potentially change over time. That's not necessarily set in stone. And so as things change over time, potentially prices, the overall cost effectiveness of Aflibercept versus bevacizumab might change as well.
And we may get other agents or other delivery systems. So I think this will be a constantly moving field. And we're so thankful to you and your collaborators for putting this information together and giving us an important outcome or follow-up from Protocol AC. And this should help us as those new agents do come out, giving us a template of how to investigate them in the future. Dr. Hutton, I want to really thank you and your group for putting this information together.
Well, thank you for the opportunity to share our results with your listeners.
We've been speaking with Dr. David Hutton, an associate professor of health management and policy at the University of Michigan School of Public Health in Ann Arbor, discussing the cost effectiveness of Aflibercept monotherapy versus Bevacizumab-First followed by Aflibercept if needed for diabetic macular edema. I'm Neil Bressler with JAMA Ophthalmology. This episode was produced by Daniel Morrow at the JAMA Network. The audio team listed alphabetically include Mary Lynn Ferkaluk, Audrey Foreman, Lisa Hardin, Hannah Park, Shelley Steffens, and Dr. Linda Brubaker, senior editor for Multimedia. Thank you for listening.